incontinence patient. Shall we start now? Welcome back, everyone. I hope you got a good coffee break. It's my pleasure to introduce my colleague, Mr. Dasgupta. He's qualified from India, and then he's a subspecialist in the field of urogynecology. He did his subspecialty training from Leicester and has been consultant in Royal Derby Hospital since 2010. He has been college tutor for 4 years, ACD, and has done CD role for 5 years. He has been chair of East Midlands Pelvic Floor Society, and he is very well known as he has participated in a lot of various national studies and sponsored drug trials. And he has been a national trainer for the AMS mesh as well in the past. So here you go, Jay. Floor to you, please. Thank you.
Thank you, Bhavna, for the introduction. I will straight away start. Is it? Can you see?
Yes, we can see your slides if you put them onto slideshow. Yep, that's great.
Yeah, right. So I'm going to talk about pelvic organ prolapse classification and through assessment, basically. And this is very relevant in clinical field because depending on what we find, how we diagnose, that tell us how we're going to manage it, and particularly if the surgical intervention is needed. Quite often we get the referrals from the GP saying that this patient is having rectocele, please get it sorted, and the patients were told that she's having rectocele. And when you see her in the clinic, she's actually not having rectocele, she's having cystocele. So this is a very common finding all of you are encountering throughout the country or elsewhere. So we should have a good sort of understanding how we all, through the same sort of knowledge, say the same language, through the same language, we understand the classification. So this is a definition, standardization by International Continence Society through 2002 meeting, where we define pelvic organ prolapse as the descent of one or more of anterior vaginal wall, posterior vaginal wall, and the apex of the vagina, which is either uterus or cervix, or the vault after hysterectomy. You note that it's the area rather than the specific organ, such as the bladder prolapse or the rectal prolapse. We have shifted to mentioning anterior vaginal wall or the posterior vaginal wall. So anterior vaginal wall prolapse is a pathological descent of the anterior vaginal wall and overlying bladder base so that the urethrovaginal junction is coming down, which is a 0.3 centimeter proximal to the external urinary meatus, or any anterior point proximal to this point, but less than 3 centimeter above the plane of the hymen. Later on the slides, I have some diagrams to sort of clarify that when we talk about the POPQ. As I mentioned, the ICS prefers the terminology anterior vaginal wall prolapse, as physical examination does not allow exact identification of the structures behind the vaginal wall. Now, you may say, well, we all know in the anterior vaginal wall, the behind is bladder. Is it always?
So sorry to interrupt.
Jay, your slides aren't moving for some reason.
Oh, it's not
We're
moving.
still on the first slide.
Oh, I'm so sorry. Is it moving now?
No. Okay, do you want to stop sharing?
Okay, Justice. Has it moved now?
No.
No movements at all?
No. Shall I put?
Just 1 second.
Jay, I'll put it up for you. I think.
Can you see now?
Can you, Jay? Do you want me to share it for you?
Yeah. Is it moving now?
No. I think I've put it up, and just tell me to move to the next slide.
Okay.
Can you people see it moving? Jay, can you see that?
I'm moving now.
Yes, it did move. Yeah.
So I'm sharing your slides, Jay.
Oh, you're sharing.
Yeah, just tell me to move to the next slide.
Okay. So where are we now?
We're on. Can you see them?
Well, I am moving from my computer.
We can't see your slides moving. So
this is.
Okay. Do you want to start sharing again, Jay? Sorry. Start sharing again. And if it doesn't work, I'll put the slides up and you can tell.
Okay, just 1 second.
Just bear with us, guys.
Sorry, I think you probably have to. I don't know why this is not happening.
I'll share it, Jay. That's fine. Okay, can you see that? Jay?
Yeah, I can see.
Can everybody see the slides?
Yeah,
Yes.
That's fine. Jay, can you see the slides?
Yeah, I can see now.
All right, tell me to just say next slide and I'll move it on.
Okay. So next slide. So we'll talk about it now. So anterior vaginal wall. I was talking. Sorry about this. So anterior vaginal wall. So we normally see the bladder behind it, but not always. Why? Because if you see the rugosities, vaginal rugosities there, quite prominent, then most likely the bladder is higher up. So in the uterovesical space, there is no bladder there. Bladder is higher up, hence the rugosities are there. So it's mainly an apical prolapse. If you can try to recollect what Osama was saying earlier, so it's most likely an apical prolapse that is happening. Whereas if you see tense, bulging, smooth vaginal wall without the rugosities, then most likely it's the bladder. So that's why it is quite difficult to actually say that it's cystocele or not a cystocele. Similarly, next slide, please. So similarly, in the posterior vaginal wall prolapse, it is defined as a descent of the posterior vaginal wall. So the midpoint of the posterior vaginal wall, 3 centimeters above the level of hymen, or any point proximal to this, less than 3 centimeters above the plane of hymen. That's how we define it. But quite often, it is difficult to differentiate an enterocele from a rectocele just by looking at it, unless you are actually physically there by dissection during the surgery. Cervical descent or the apical prolapse is depending on the position of the cervix in relation to the hymen. And post-hysterectomy vault prolapse is also apical prolapse, depending on the position of the apex or the vault of the vagina in relation to the cervix. Next slide, please. A little bit of epidemiology from the prolapse perspective. Lifetime risk of prolapse is about 11%. 50% women over 50 are symptomatic of prolapse. Around 30% will need reoperations within 5 years. Recurrence most common in the anterior compartment and can be up to 40% after traditional colporrhaphy. The failure and recurrence are related to poor quality of tissue, technique of repair, associated comorbidities. These are somewhat old data, but I don't think there's been much change on this. During this, for the last 10 years or so, mesh came into the market, but it did not change the recurrence or any outcome that significantly. Regarding the post-hysterectomy vault prolapse, up to 40% women undergoing hysterectomy, either abdominal or vaginal, they can have vaginal vault prolapse. About 20%, about 12% after prolapse, and about 2% after benign disease. And of them, less than 10%, they may need prolapse repair. How do we prevent it from this happening? Can we do something during hysterectomy? We can do macrocalvoplasty procedure when we do vaginal hysterectomy. People have done cardinal ligaments, uterosacral ligaments plication to the vault. Sometimes we can do sacrospinous, concomitant sacrospinous procedures when we do vaginal hysterectomies. So we are taking all these steps to minimize the vault prolapse. But longer studies are required to substantiate this. Subtotal hysterectomy is not recommended as a preventative procedure because sometimes in past we had a thought that maybe if we preserve the uterosacral ligaments and do a subtotal hysterectomy, that might stop vaginal vault prolapse later on, but that didn't really translated in clinical practice, so it's not recommended. Next slide, please. So talking about what causes pelvic organ prolapse. To understand this, we have to go back and recapitulate what Osama was trying to say at the levels of prolapse, the anatomy, which keeps the organs, pelvic organs in place. Pelvic organs means bladder, uterus, and rectum, mainly along with obviously the vagina. Anything that disrupts these structures that can cause prolapse. The first trauma is the pregnancy and childbirth, and then aging and menopause. We'll talk a little bit more about pregnancy and childbirth first. That obvious disruption in the vagina and the subvaginal levels such as the puboversical fascia, rectovaginal fascia, pubourethral, pubocervical ligaments. These are all condensations of endopelvic fascia. So the fascial damage, which is almost inevitable during childbirth through vaginal delivery or in instrumental delivery particularly. And then when the regeneration happens, it may not happen the same way it was before, particularly as we all know the muscles don't regenerate. So it's all through the scar tissues, which may not be as strong as is expected. Aging process and the menopause, there's a change in collagen, again affecting the subdermal level, subvaginal, mucosal level, endopelvic fascial levels. The changes happen, the collagen, nature of the collagen changes, which contribute to the laxity, chronically raised intra-abdominal pressure, chronic constipation, chronic cough, high BMI. This group of patients are more common now due to the changes in the lifestyle and diet and etc. So all these are concomitant pressures on the pelvic organ prolapse manufacturing, really, to be honest. Previous pelvic floor surgery, such as colposuspension, can sometimes cause rectocele, posterior vaginal wall prolapse, because we suspend the anterior vaginal wall efficiently. So the pressure now, rather than going to the anterior vaginal wall, is transmitted to the posterior vaginal wall. Denervation or weakness to the pelvic floor, to a variety of reasons, including previous childbirth and previous trauma through surgery. Some genetic predisposition, connective tissue disorders such as Ehlers-Danlos, etc. So all these things can eventually, either in singulation or in association, they can provide the etiology for pelvic organ prolapse. Next slide, please. I'm not repeating what Usama was said, just to recapitulate again the levels of support. Level 1, uterosacral and cardinal. Level 2, pubocervical and rectovaginal. And level 3 is the urethral hammock. So vault prolapse or apical prolapse is due to the level 1 support. Pubocervical and rectovaginal fascia, the level 2 support gives cystocele and rectocele. And level 3, usually the sexual dysfunction, stress incontinence, perineal body deficiency, etc. Thank you. Next slide, please. This I was telling you before, that the anterior vaginal wall prolapse, the rugosities are very important. The paravaginal defect, the slide on the right side, you can see the rugosities are there, but you still get a prolapse there. So there, most likely it is primarily it's an apical prolapse. Along with the bladder is coming down, the rugosities are maintained because the pubocervical fascia is intact there, whereas the lateral defect, lateral separation from the white line, and due to that, the prolapse have happened. So if you don't identify the defect there, and you do not do, when you're doing the surgical repair, if you don't acknowledge and appropriately fix the defect through paravaginal repairs, you won't be able to lift up the prolapse. So a simple midline fascial plication will not correct the problem. Whereas if there is a midline defect, which is cystocele with a smooth traditional finding, when we see, most of the time that's what we found, and where the pubocervical fascia is disrupted and you get a big cystocele there, then I think traditional midline repair is acceptable. Next slide, please. So before we actually examine the patient, we need to assess through the symptoms. And there are various ways of accepting and acknowledging the symptoms through appropriate history taking. There are validated questionnaires there. We can get those questionnaires done before the patients actually arrive, where what Sheffield they used to do, they're still doing it through the generic e-questionnaires. We can move to the next slide, please. So Sheffield's specific questionnaires, there are 25 questions, 5 domains. As you can see, the lump and the pain, bladder function, bowel function, sexual function, and how it is affecting the impact of prolapse on life. So these are validated questionnaires, and when we assess them, we have a better understanding that the patient's main bother and how we address that. For example, patients are referred to us with a cystocele. Now, when you examine them, you don't find a significantly big cystocele, but talking to them, you found that the main problem is sexual dysfunction. So if you do not address that symptom and you simply put a pessary in or try to do a prolapse repair, which are traditional management for prolapse, you'll miss the boat. The satisfaction from your treatment will be very poor from the patient's perspective because you haven't addressed the symptom. So it is very important to acknowledge in the prolapse field, in the urogyne field, we are dealing with lifestyle. So it's not the objective finding, it's always subjective supported by the objective. So hence, it's very important to acknowledge that and address it very astutely and as sort of perfectly as possible. Quite difficult at times because we deal with the elderly people who sometimes cannot articulate very astutely what exactly they want from, but we try to get it through these questionnaires, through proper history taking, which takes time. And each domain symptom assessed the degree of bother, and that's we collect them and we rank them, and that's how we try to finalize how we are going to manage these patients. Next slide, please. As you can see, quite prominent and predominant symptom as they describe is a bulge, a protrusion of a tissue, a bulge. That's the most bother. That's coming in the way when they're having sex. That's causing problem when they pass urine, some sort of voiding dysfunction. They describe the symptoms of defecatory problem impacting them when they're walking, they're exercising in the daily life. Quite often pelvic pain and discomfort. Sometimes bleeding and discharge as well, particularly if they have a big protrusion outside, constant irritation with underwear. Some of them, they're already using pessaries, which is causing ulcerations. Next slide, please. How do we quantify this? How do we grade it? Conventional staging, first degree, second degree, and third degree. First degree is within the vagina, second degree is just up to the introitus, and third degree is outside. Bed and walkers is halfway through up to the hymen beyond. It's pretty much conventional bed and walker, they're pretty much same. It's easy to do that way. But if we try to be more specific, and particularly if we talk about MDTs, how we reproducibility, and when we assess post-operatively, how do we analyze, and that perhaps needs a better assessment. Hence, ICS came up with a objective analysis of this assessment, which is called pelvic organ prolapse quantification, POPQ, which most of us we did do now. It started in 1996. It is more reproducible and sensitive way of measuring. And it can be summarized in different grades of severity, and it is recommended in clinical practice. Next slide, please. So how do we do it? We put the patient in lithotomy position, ensure the bladder is not full, and we try to measure the total vaginal length at rest, and we should do the assessment with maximum straining with Valsalva. We ask the patient sometimes to block the nose and press and bear down. Next slide, please. And we try to identify the points in the anterior vaginal wall. Urethra, 3 centimeter below the urethra is point A. C point is the cervix. Between C and point A, where the most predominant dependent point is the B, and that's the most important point. So when the patient is bearing down, we try to identify the most dependent point. That can be the point A or beyond it. And hymenal ring is noted to be 0. Any points above the hymen is negative, any point below the hymen in positive. And this is applicable both in the anterior and in the posterior wall. Next slide, please. So as I said, point A, 3 centimeter below. Point B is the most dependent point between the point C and point A. Next slide, please. In the posterior, very similar application, but over here, obviously, the 0 is the hymen. Point A is 3 centimeter above on the posterior vaginal wall in the midline. And point B is the most dependent point again from the point D, from the point hymen and the point A. So it can always be beyond point A. And point D is the highest point in the posterior fornix. Next slide, please. Perineal body is PB, is the distance between the fourchette to the middle of the anus. Genital hiatus is from the fourchette to the urethral meatus, and TVL is the total vaginal length. And the measurements of all points should be nearest to 0.5 centimeter. Next slide, please. So stage 0 is when all the points I described, they're at that position. That means there is no prolapse. Stage 1 is when the stage 0 is not met and the leading edge of the prolapse is less than 1 centimeter. Stage 2 is beyond 1 centimeter, but less than 1 centimeter inside. And stage 3 is the leading edge of the prolapse is beyond 1 centimeter. And stage 4 is beyond 2 centimeter. Next slide, please. So if you can see that this is the symphysis pubis, bladder and cervix, and this is the anal sphincters. Next slide, please. So this is genital hiatus. Next slide. Point A is 3 centimeter beyond, 3 centimeter below the urethral meatus. That's the most dependent point is between cervix and the point A is point B. That's the anterior wall. Next slide, please. That's a point C. Next slide, please. Point A on the posterior vaginal wall, which is 3 centimeter above the hymenal ring. And point D is up there. And between that and the point A is point B, the most dependent point. Next slide, please. That's a point D high up. So this is the POP-Q anterior wall. And then the posterior wall down there. Genital hiatus, perineal body, and TVL. Next slide, please. So there is no prolapse there. So I'm just putting, so next slide. Next slide. Next slide. Next slide. And this is total procedentia, as you can see. And we put the numbers there. Okay, so next slide, please. Okay, we'll stop here. The management will be discussed in the later talks. So any questions? At this stage, otherwise we'll move on to the urinary incontinence bit. Sumi, shall we move on to the urinary incontinence?
I had
Jane?
a question if you don't mind.
Sorry, Manal has had a question. Manal, do you want to ask a question?
Yes, please. We mentioned about the Sheffield questionnaire. Can we use this questionnaire in our unit, or we can't use it locally?
Did you get that, Jay? Hello? Hello.
I will answer that, Sumi. So Sheffield, this questionnaire is not available for free. So you have to buy this. It's called EPAC, Electronic Personal Assessment Questionnaire. So you have to buy it. So you can't use it for free. But if you pay, then you can use it. Yeah.
Thank you.
Okay. Suranja, do you want to ask your question? I'm not sure whether
thank you.
Jay may have just lost connection, but hopefully he'll be back
I
on in a
don't
minute.
see Jay is there now, but
If you ask your question, but Bhavna will try and answer it.
yeah,
I'm here.
thank you. Oh, hello,
Can you see
Jay.
me?
Jay, you
Hi.
back? Turn your camera on. Sorry, we just had a question about whether they can use a Sheffield questionnaire, and Bhavna's answered that, saying you've obviously got to pay for that. And now Goshal's Suranjan is asking a question. Fire away. Jay, do you want to turn your camera on because we can't see you?
My camera is on.
We can't see you. Not sure.
Can you
what's
hear
going on.
me?
We can hear you, but we can't see you.
Shall I ask my question?
Yeah, ask your
Yeah,
question,
please
please.
do.
Okay, my camera is on as well, as you can see. It's not showing me. It doesn't like me, I think. So,
Okay,
Jay,
that's fine.
thank you very much. Very nice talk, and I enjoyed it. My question is, how do you think vaginal prolapse associates itself with pelvic pain and nausea?
Pelvic pain.
It was on the slides. Thank you.
Sorry, vaginal prolapse is. Yeah, sorry, I didn't get the question. So
because one of your slides showed in the symptomatology, pelvic pain and nausea as symptoms.
Yeah, it is through the questionnaires. When they did the questionnaires, they found one of this aspect in the nausea. I'm not sure why the nausea is there, but I guess maybe if they have some concurrent sort of tumors or something which presses. So why they're having nausea? It's one of the things which is I can't explain why it is there. It is not my routine practice. In my clinical practice, I find nausea there, but it is there in one of those questionnaires.
Okay.
So it's difficult to explain why.
Shahid Naveed, thank you. Shahid Naveed, you want to unmute yourself? We can't hear you. Sorry, Shahid, you're muted.
Apologies. So, sorry, I've got late in clinic, joined late. The question I wanted to ask was these symptoms, which we don't promise patient to resolve after dealing with the prolapse, whether it's conservative or surgical management. I never promise patient that her pain will get better, because pain is not a symptom of prolapse, as far as I have knowledge and understanding of prolapse. Dyspareunia, again, is not a symptom for prolapse. I don't promise patient that these symptoms will settle. To some extent, bowel dysfunction, the splinting of bowel, yes, agree that will get better, and incomplete emptying of bladder will get better after surgery or pessary. Main symptom which I promise that will get better will be the protrusion, physical presence of prolapse. So I'm not sure why this personal questionnaire, electronic personal questionnaire has got all these in. The question may be after surgery whether they develop pain and sexual dysfunction. That's an important question to ask. If there is a pre-existing one, you don't actually give any importance to that, because you tell patient that this is not something I will get better with the prolapse repair. What I don't know what is the reason for putting in the questionnaire.
I think, can I take this question? So I think the importance of understanding patients' symptoms will help us basically to give them, as I said before, that if the patient's problem is mainly pain, as you said, then we have to address the pain. If the sexual dysfunction is there, then we have to address that. If the concomitant overactive bladder problems along with cystocele is there, then we have to address that. If there's defecatory problem there, in absence of prolapse, then we have to address that, because we see sometimes patients when they come, they say that their main problem is defecatory problem, but when you examine them, there is not much prolapse there. So in that case, we need to involve the colorectal team rather than just doing a rectocele repair on a very small rectocele. So I think there is an importance of addressing these questions, but it depends on your practice and what kind of patients you're seeing, and you know.
Okay, fantastic. Jay, shall we move on to your next talk, because we're going to run out of time otherwise? Okay.
Yeah, sorry. Yeah,
that's fine. Let's have a look. That's this one.
Yeah, thank you. So I'm going to talk about just the basic of urinary incontinence. Can we put it on the slideshow?
Yeah, you got it.
Yeah, thank you. So as you can see, urinary incontinence is quite a predominant problem in the community compared to the other more, the comorbidities such as diabetes, depression, hypertension. Just to give you a background. Next slide, please. So to define urinary incontinence is the complaint of involuntary loss of urine. Stress incontinence is the complaint of involuntary loss with an effort of physical exertion. And urgency is a complaint of involuntary loss associated with urgency. There are other incontinence there as well. I will focus on mixed urinary incontinence, which is more common in our practice, which is combination of both urgency and the stress incontinence. I will just skip this for now. Epidemiology is very predominant. We keep us going, keep us in business. So overall incontinence rate is about 25 to 38%. The EPICON study, which is the biggest Norwegian trial, 25%. Mixed urinary incontinence, 50%. 25%. Stress incontinence about 50%, and mixed is about 36%. Urgency 11%. This is overall spread, just to understand that how we see patients in the overactive bladder group. Urinary incontinence in the UK, women much higher than men. In UK-based population study, about 40% incontinence, urinary incontinence. Overall, stress incontinence is 1/4, more in younger and middle-aged group. Overactive bladder and urgency incontinence less than 10%. Mixed incontinence about 20%, and it's more in the elderly population. We'll go to the next slide. As you can see, 65 and above, very severe, moderate. So the severity has increased in the elderly population, and how the overall severity got more and more when ladies, they get older. Next one, please. We deal with quite a big geriatric population, and we know that urinary incontinence is quite a problem in the geriatric population along with other comorbidities, and we have to acknowledge that, because that affects overall life. For example, she's having nocturia, she's getting up at several times at night, she's falling down, breaking her hip, and so on and so forth. So how a simple incontinence can cause fatal morbidity. So bladder architecture changes with time, increase in the collagen in association with greater age collagen. The muscle is more than 53%. Infiltration of the smooth muscle bundles, changes in the nature of the collagen also depends on less vasculature, like ischemia. Here it's what probably mentioning that smoking can cause that problem as well. We'll move to the next slide, please. So with age, the maximum bladder capacity falls in association with age. Functional capacity changes, decreased sensation. We move on to the next slide, please. So decreased sensation, decreased capacity, all these things are age related. It's called aging bladder, which is difficult to overcome. Bladder retraining helps to some extent. Urethral function changes, lower urethral pressure found in both sexes in association with increased age. The urethra becomes less compliant and able to resist less pressure. Again, that is due to multiple factors. One important factor is in and around the urethra, the supports of urethra, the pubocervical ligament, the change in the collagen there, the increased stiffness of urethra and bladder in association with the age. Next slide, please. So nocturnal frequency, polyuria, all these things come with age due to various other reasons: loss of renal concentrating capacity, loss of diurnal ADH and ANP secretion, increased GFR in supine position, physiological changes predisposed to nocturnal urinary frequency. The reason I put this slide, because this is something which we come across quite often, patients coming to our clinic, main problem with nocturia. There's increased 24-hour urine volume output, increased urinary frequency, reduced ability of the kidney to concentrate, etc. Next para. So, and along with the comorbidities such as diabetes, overweight. Next slide, please. We talked about this. Next slide, please. Impaired mobility. We talked a little bit about that, which is obviously a problem. And along with urinary incontinence, increased the problem with falls. Next slide, please. So overactive bladder is urinary urgency associated with frequency and nocturia, with or without incontinence, OAB wet or OAB dry. Next slide, please. Next slide, please. So overall prevalence is less than 20%, 17 to 20%. Prevalence increases with age, 4.8% in women under 25 and about 30% over 65. Frequency is the most common reported symptom, as you can see, about 85%, followed by urgency and urinary incontinence. 2/3 of the OAB patients do not have incontinence. Next slide, please. So detrusor overactivity in both sexes is associated with lower bladder capacity and advancing age, which we discussed earlier. Sensation of bladder filling in the older people with DO is increased. Contraction strength is decreased compared to the younger people, and urethral resistance is increased. So we focus on urgency and urgency incontinence. Urgency is a drive mainly for the frequency. So we focus on that. So it's a little talk on the normal micturition. So bladder gets filled up. We talked about it's like a aerodynamic section. The bladder gets filled up. We shouldn't have any sensation during bladder filling. Once the bladder is filled up, the sensation comes from the brain, tell the bladder that you should go now, but we should be able to hold the bladder till we reach the toilet. When we reach the toilet, brain tells the bladder, now you contract. The urethral area, bladder neck area relaxes, and we empty your bladder through micturition cycle. Next slide, please. We'll jump this slide due to time constraint. Next slide, please. So here, sorry, the previous slide. Yeah, so as you can see, bladder is under control, the parasympathetic and sympathetic. I think it's worth spending at least some time on this to understand the overactivity. So normally at a rest stage, the parasympathetic system is sleeping. And during the emptying phase, the parasympathetic system is active, and vice versa for the sympathetic system. Next slide, please. So as you can see, the nerve endings, the antimuscarinics are there, which work on the receptors to block it. So that's where the antimuscarinics work. Next slide, please. So continence is maintained in the storage phase by inhibition of parasympathetic system. It sleeps. And activation of the sympathetic system, which helps bladder relaxing and urethral sphincter to be in action. And avoiding phase, exactly opposite happens. So parasympathetic inhibits the sympathetic system and activates the parasympathetic system. Next slide, please. We see that, I think we can escape this slide because we talked about how it increases. And the stress urinary incontinence is, next slide, please. Mainly two different causes. One is anatomic defect of urethral hypermobility. That's most commonly, that's what causes the stress incontinence. And our main surgical intervention is directed to that. And the other one is neuromuscular defect, which is intrinsic sphincter deficiency, which is more difficult to actually identify. And Bhavna talked about the urethral profilometry, pressure profilometry, and those things will come. This is beyond our remit. Urologists, they deal with it. Intrinsic sphincter deficiency with artificial sphincters, very small proportion. Sorry, it's a bit rushed because of time constraint, but I'm happy to take questions up till here.
Thank you, Jay. I think we've probably got at the most time for one question. Any questions at all for Jay? Thank you for a fantastic talk, Jay. That was brilliant. Somebody, let me just see. Mariam Mala, do you want to ask your question? If you will unmute yourself, Mariam. Mariam said, would perineopathy used routinely when treating posterior prolapse? Would it help to improve dyspareunia or make it worse?
I do not do routine perineopathy. It depends on the findings. If there's a perineal body deficiency and along with symptoms such as defecatory problem and the patients had to push and support the perineum during defecation, then I do the perineopathy. And yes, perineopathy sometimes can cause dyspareunia, particularly with tight perineopathy. When I put stitches, I don't come very superficial. So yes, it can cause dyspareunia. So we have to be careful doing the perineopathy, not to do too tight.
Okay. Thank you very much, Jay. Shall we move on, Bob?